Good evening, everyone. It's March. March Madness is going on. I want to thank you for joining this March Madness presentation. While we're not talking about basketball, we are talking about men's health. We have the privilege and pleasure of having Dr. Bryan Voelzke with us. He is a urologist, a men's health specialist, truly an expert in this area, and he's going to be giving a presentation on life after prostate cancer, talking about the signs, symptoms, and treatment options for a couple of common conditions experienced after prostate cancer treatment, and those are erectile dysfunction and stress urinary incontinence. Now, this is not a fully interactive. It is a somewhat interactive presentation. You can ask questions anytime, and we encourage you to do so. To submit your questions, you're going to tap the screen of your mobile device if you're on one, or move the mouse on your laptop or desktop. You're going to see a toolbar pop up. One of those tools is a chat box. Double click on that, type your question in, hit enter, and we will get to those questions at the conclusion of the webinar. For those of you that already submitted your questions, thank you. We will get to those as well. Now, without further delay, I want to introduce our host, Dr. Bryan Voelzke.
Yeah, thanks, Mike, for introducing me. Thanks, Boston Scientific, for being a partner and also being committed to men with sort of these sort of health issues after prostate cancer. So just a little bit about myself. I'm at Spokane Urology. We have an office on Trent Avenue. I probably should update this slide. We're also on Mission in Spokane Valley. I am a urologist. I did my training at Loyola University Medical Center and just outside of Chicago in a town called Maywood. And then I specialized after my residency in sort of urologic trauma and reconstruction in San Francisco. I did spend a year in Melbourne, Australia. Prior to that, just kind of waiting for my spot in line to do the fellowship. While that was fun in Australia, the bulk of my training though or my practice kind of focuses on reconstruction. I was at University of Washington for 10 years where I did more urologic trauma at Harborview. Still did quite a bit of reconstruction, but since moving to Spokane in 2019, my practice is primarily focused on reconstruction, and I kind of cover a little bit of everything in my practice. But I also do specialize specifically also in stress urinary incontinence and erectile dysfunction. And that's what this talk will be about. So just to give an overview of what we're going to chat about, I'll kind of talk a little bit about prostate cancer. I'm not going to get a lot into the weeds. Most patients on this slide or this talk have prostate cancer, or maybe have a family member that had prostate cancer, or maybe just decided to log in just because they want to hear about stress incontinence and erectile dysfunction. So I won't spend a lot of time on that. It's more the treatment options for stress incontinence and erectile dysfunction. So this slide shows men and women, sort of estimated new cancer cases in 2024. We all know men have a prostate, women don't, but it just kind of shows where the estimated new numbers of cancer cases are in the United States. And you can see prostate, most common new cancer case in 2024 in the United States, roughly a third. While it is a high number or percentage of patients that have prostate cancer, what you'll see in subsequent slides is that patients typically fare well at their 5-year survival. And I think this is where this talk kind of comes into play. Men survive their prostate cancer and they want to get back to where they were before their prostate cancer. Maybe the cancer treatment impacted their urinary control and or erectile function. They want to feel whole again. And that long survival, which prostate cancer affords, allows these sort of, for better or worse, allows these health issues to kind of rear their head. And that's where we come in urology to try to get men back to where they're feeling confident. So this slide here, I put in mainly just to show, because sometimes patients will come in and sort of ask questions about, where does prostate cancer fall among other cancers? And this graph here just shows different fairly common cancers diagnosed in 1975 all the way to 2020. And you can see most of them have stayed relatively stable. With colon cancer screening, colonoscopy, they're finding polyps sooner, so those aren't progressing to cancer. So you can see the incidence of colon cancer's fallen. Smoking cessation, you can see lung cancer's also fallen. You see a big peak in 1990 in prostate cancer, and that looks really weird. And people are like, what happened in 1990? Well, that's when PSA testing came out. So you all of a sudden had something beyond just rectal exams. So before we would just do a rectal exam, and if the prostate felt fine, It felt symmetric. We didn't feel any hard nodules. We just assumed the patient didn't have prostate cancer, and we kind of moved on in the visit. However, after PSA screening came out, we could actually had a number and we could follow the PSA value. If the patient had a normal feeling rectal exam, but their PSA value kind of rose up over the years, which we call an increasing PSA velocity, we then subsequently did a biopsy and found all these cancers that were just previously not diagnosed. So that's where you see this rapid climb. And then what happened is we realized we were diagnosing a lot of men who probably didn't need to be diagnosed. And the U.S. Preventative Task Force Committee kind of put out statements saying, look, in men that are 72 to 75, in their study, I think in 2008 they said 75, but roughly 72 to 75 are men that have a less than 10-year survival rate because of other health conditions. We should not be doing PSA testing. So you can see that that's when the incidence of prostate cancer diagnosis fell, because we weren't looking in certain patients who this is probably more than people in the talk want to know, but they've actually done cadaver studies among men in their 70s and 80s who died from other causes, and they actually looked at their prostate. And a lot of men die with prostate cancer. I try to explain to patients, think of prostate cancer as like it can either be an extrovert that wants to leave the prostate and explore the rest of your body, or it can be an introvert that's just content to just live in your prostate, doesn't really want to bother anyone, just kind of wants to be left alone. And a lot of men in their 70s, 80s have introvert type prostate cancer. It just wants to live in their prostate. It's never going to really spread. And not checking for that lets these patients not be overdiagnosed and overtreated, maintains their quality of life. However, if you diagnose these patients in their 50s or 60s, there's a long enough time period to where the cancer could become more of a problem. And that's why we recommend sort of screening when men turn 50, and we kind of turn off the screening when men hit their 70, 72, 70, or 72 to 75. As far as estimated new cancer deaths in 2024, you can see lung cancer does sort of vault above prostate cancer. So while there's still 11% of men new cancer deaths in 2024 from prostate cancer. We know that it is a deadly disease, so it doesn't mean we want to stop screening for prostate cancer and sort of put our heads in the sand. So I do still recommend screening. There's definitely primary care doctors out there that say we don't need to screen for prostate cancer. I disagree with that. I think it's better just knowledge is power. It's better to be screened and be worked up. If you do have prostate cancer, there's many men nowadays that, if they fit the criteria, we can put them on active surveillance. We don't have to treat their cancer. Sounds sort of weird to say this, but we can just let the cancer live in the patient's body and not treat it and just actively follow their PSA. Doesn't mean we want to ignore it. We want to screen them and follow their PSA, maybe repeat a biopsy, but try to defer treatment for as long as we can. So this is what the slide that I really wanted to focus on, though. You can see when you look at 5-year survival, even though prostate cancer was high on, new diagnoses and deaths, it does have a high 5-year survival by race between 2013 and 2019. You can see between 97 and 98%. So a lot of these men have been diagnosed with prostate cancer. They've been treated, and now maybe there's not a complication, but there's something that's happened after their treatment. Maybe the erections have taken a hit. Maybe they've got some issues with urinary control. And now they want to make that whole again. And that's where we come in as urologists to try to fix that, to improve quality of life, make patients feel better. Just a little bit about the anatomy. The prostate, think of the prostate as like a donut. The middle of the donut is the hole that you pee through. And then the cake part of the donut is the gland. And that's what we're biopsying when we're checking for prostate cancer. The purpose of the prostate is there's a tube, the testicles make semen that kind of go through the vas, and then they spit out this sort of ejaculatory fluid through the prostate. So that's the purpose of the prostate. And of course, after the prostate's taken out, if you have prostate cancer and you have surgery, when you ejaculate, it's a dry ejaculate because the prostate's not there anymore. So during the surgery, the prostate is removed. I'm not sure if you can see my pointer, but the prostate's removed, and then the urethra down here is just sewn up to the bladder. That's with surgery. With radiation, you're directing the radiation to the prostate. Prostate stays in place. However, with radiation, you've got the rectum that's around here. You got the bladder up here. So trying to improve radiation to where you don't get scatter affecting other organs can be helpful. How do we diagnose prostate cancer? like we talked about earlier, PSA testing, and there's different types of PSA tests we can do, like a free to total. There's other screening tests we can send off that give kind of a risk. And then a digital rectal exam. I still employ digital rectal exam in my practice, but I really rely more heavily on the PSA. And then, of course, when patients come in, I saw a patient today with gross blood in his urine, had some obstructive voiding symptoms. I did a rectal exam, which felt very concerning. I felt some nodularity, and then also scoped him because of the blood in his urine, took a scope and looked inside the urethra, and you could see, kind of an irregular appearing prostate. So sometimes it manifests as other symptoms, brings patients into our practice, and once we work them up, we can find prostate cancer. Treatment options, and I won't go into this. There's different types of radiation, or I guess probably a better way to say it is energy ablative treatments, because you can do HIFU, high intensity focused ultrasound, or cryotherapy for the prostate. That's not necessarily radiation, but it's an energy ablative treatment. There's also external beam, different types of external beam. There's brachytherapy or brachytherapy, where you put seeds in the prostate that can be permanent or just temporarily put in and then removed days later. Then there's surgery. Used to be open robotic surgery or open surgery. Now it's primarily just done robotically. That's pretty much what dominates surgery now. And then active surveillance. These are patients who have kind of a low volume cancer that's more of that friendly type of cancer, that it's not an aggressive pathology score, that we're just watching and we're keeping an eye on them, hoping that it doesn't progress. But if it does, then we'll jump in and talk about maybe surgery or radiation. So now we'll talk about urinary control. So, the two things I want to talk about, sort of life after prostate cancer. We'll first start with the urinary control. This is primarily stress incontinence. So we're not talking about, while some men can have urge incontinence, where they get the urge to go to the bathroom and they can't get to the toilet in time, that can happen after prostate cancer treatment. You can also have functional incontinence, where mobility affects you to actually get to the toilet and urinate into the toilet, so you actually end up leaking yourself. Those are two separate treatments, or two separate topics. We'll kind of focus more tonight on stress incontinence, which is that leakage that happens when you cough or sneeze, or you maybe bend down to tie your shoes, or you laugh, and that increased pressure in the abdomen, the muscle sphincter that's supposed to close off and keep the urine in your bladder doesn't work. So the urine just leaks out through the urethra. That's called stress urinary incontinence. You may see SUI, just an abbreviation. I've tried to eliminate most of the abbreviations so it's not getting too over everybody's head. So bladder leakage, it can vary. It can just be a couple drops of urine with activity to being, kind of a drippy faucet that just leaks continuously. Most men, after treatment, primarily surgery, robotic prostatectomy, the urine leakage will improve weeks to months after surgery. Most patients within a year will regain bladder control. However, for patients that don't, or that have any degree of incontinence, it can be mild, moderate to severe. I try to tell patients you don't have to have severe incontinence to be bothered. You don't need to apologize. If you're coming in and you're bothered, it bothers you, and you're your own individual. You're the one living in your head with how it affects your life. And it can affect daily life. When I was at the University of Washington, we gave questionnaires to patients before surgery that looked at stress incontinence, and we gave questionnaires to patients after. And it was only asking, what is your quality of life? How happy are you? And noticeable, statistically significant improvement after you treat someone with stress incontinence. I mean, they feel better. It can affect many things. I mean, men can say, I don't want to get out of the house. I don't want to go eat dinner. And the spouse or the partner who's been with that person forever, they want to support their husband, but they also want to get out and enjoy life with their husband. They don't want to see him kind of, sitting on the sidelines and not being involved. So, it can be a significant impactor for patients. And you do this long enough and you see these patients after the surgeries, and it just really can make a big difference. And it's one of the things I really enjoy about my practice. I tried to find some data showing kind of the incidence of leakage of stress incontinence after surgery and after radiation, because and even doing that, it's like comparing apples and oranges. But like I said before, most men reach full urinary control within a couple of months. And there's some things we talk to them about, and I'll kind of get to this in a second, to kind of help improve their urinary control. And by the time you get a year out, you look at a bunch of studies, most of them between 90, 70 to 90, high 90%, most of them have urinary control. Urinary control being like not wearing a pad, and back to kind of where they were pre-surgery. I'd say stress incontinence that's significant where you're just leaking continuously. Like I tell patients like should be, 1% or less. So that's very uncommon. However, there's factors that also feed into that for patients to, maybe some surgeons aren't as high volume on prostate cancer treatment. Their risk of significant stress incontinence is going to be higher than, say, the patient or the physician that has done a lot of these procedures. After radiation therapy, you look at external beam radiation, roughly about 1.5%. So not a big number of, long-term stress incontinence. With brachytherapy or seeds, a little bit higher. And the reason for that is you're actually putting these seeds into the prostate. They're radiation seeds. So you can get a little bit more irritation of the prostate. And even if it's not stress incontinence, we definitely see men that come in with more urgency, slower stream. The radiation pellets can cause the prostate to kind of swell up, and that sort of donut hole that they're peeing through is a little bit tighter, so it's harder to pee. One other big part of my practice can be scar tissue after radiation. And even after surgery, patients can get scar tissue at the site of the radiation or site of where they reconstructed the urethra after removing the prostate. And that's another thing that we can treat. And sometimes us treating the scar tissue can cause stress incontinence. So you're kind of robbing Peter to pay, or taking one step forward, two steps back, where you've now fixed their blockage, but now they're incontinent, and it's new, and they come to me or they come to somebody else because they want help with the leakage. Risk factors for incontinence, advanced age. We know as men get older, the muscle sphincter, it's skeletal muscle. So if the muscle is atrophying or kind of wasting away, you're just not going to have as much bulk strength there. And you're not, maybe when you cough or leak or cough or sneeze, the muscle's just not as strong as it was. I've definitely seen patients that have had prostate surgery done, and 10 years later, all of a sudden they have worsened stress incontinence. And a lot of time sometimes it can be bladder remodeling, but most commonly it's just the muscles that where their external sphincter is just aren't as strong as they were before. And sometimes physical therapy can help. Diabetics, nerves just recover slower. So I tell patients, if you're a diabetic, you're seeing me after you've had your surgery done. Sometimes we need to wait, sometimes up to a year. If they're improving steadily, I tell patients, just try to be patient. Let's get you through this. Hopefully the nerves can recover. Some patients, the nerves just aren't going to recover, and we can intervene sooner. Obesity, the way I think of it is just think if you've got more abdominal girth, more weight pushing down on the bladder, that's just more force, and your sphincter has to work a little bit harder to keep the urine trapped in. So we know obesity can have a risk factor. And then reduced physical activity kind of goes with advanced age. Same thing. If you're just not physically active and you're more sedentary, muscles just tend to kind of weaken. And then another big thing is just preoperative bladder urination problems. You could have an enlarged prostate, difficulty urinating, what we call benign prostatic hypertrophy, and then your bladder can kind of remodel. It's having to push so hard to get the urine out. Think of like an Arnold Schwarzenegger type bladder where the muscles are just so big and strong. And then you take the prostate out for prostatectomy. The brain doesn't know that the prostate's been removed, so it's still sending impulses down to the bladder saying, "Hey, you got to squeeze so hard to get the urine out." So some patients, like we talked about, it doesn't have to be stress incontinence. Some patients can get really bad urgency and frequency, just because the bladder's conditioned to think it's got to push hard to overcome an obstruction that's now been removed when you took the prostate out for cancer. So those things can also affect the bladder. And say if you have incontinence, stress incontinence, I try to always look in the bladder. Some patients, their bladder just gets so fibrosed from years of heavy pushing to get the urine out, it can remodel. Their bladder volume can shrink down when they're incontinent, and they may not get that bladder volume back. So I do think it's important to think about these things when you're thinking about putting the device in. Is the patient's bladder going to have enough capacity so that when we put the sphincter back in, they're not peeing like every hour? So these are all the things that the urologist should be thinking about rather than just putting sphincters in patients that maybe they didn't screen well enough. So the workup, patient history, I'm talking to the patient when I see them, have you had what prior urologic surgery did you have done? Maybe if you had a prostate resection at some point before you had radiation for your prostate cancer, or did you just have a robotic prostatectomy? Did you have radiation after the prostatectomy because your PSA was going up? Are you a diabetic? Are you a smoker? Are you on any medications that sort of compromise your immune system that may affect surgical healing? And then figuring out what type of leakage they have. Is it stress? Is it urge? How severe is it? I mean, how many pads are they going through a day? And then physical exam to kind of see from just body habitus, your appearance, kind of, is there any other concerns I might have about potential surgery? And then additional things that I always include these, even though it says additional, I include it in my practice, a 24-hour pad weight test. So I have a patient, I'll have patients weigh the pad in its dry weight and then weigh it when it's wet. If they've leaked into the pad, I used to use a digital scale, kitchen scale, and then subtract the dry weight from the wet weight. And that tells you what the gram leakage is. And you want to collect that over 24 hours. So it's called a 24-hour pad weight test. And I'll talk about the pad weight test later in the talk. It helps us to kind of figure out which surgical procedure patients would fit into. And then I like the bladder diary because I tell patients, even if you leak at night and or if you leak during the day, but you're dry when you're laying flat on your back, when you get up to pee, I give my patients a little urine meter and I pee into this, measure how much urine you made. It helps me to know kind of what your bladder capacity is. So these are things that kind of help me to think about what's the best surgery that we could do for you. And then questionnaires. I do like questionnaires because it's in the patient's voice. They get a chance to tell you how much things are bothering them. So I use questionnaires in my practice heavily. Laboratory testing, we want to make sure you don't have a bladder infection, so urinalysis. I do a cystoscopy on all my patients to make sure there's not scar tissue in the urethra, that the bladder looks healthy, that there's nothing concerning about potential surgery. I don't do urodynamics on everybody. That's if I can't figure out what type of leakage they have. The urodynamics is essentially um, pressure transducers. It's a catheter that goes in the urethra and a catheter that goes in the rectum. And it helps to sense if you're using your abdominal muscles to empty your bladder, like straining down if your bladder's not working. It also helps us to figure out how much your bladder holds. Can it fill in a relaxed manner, or is it filled and does it have poor compliance, meaning poor stretch? So those are tests that are a little bit invasive we have to do in the office. So I don't order that for a lot of patients, but sometimes can be helpful. And then x-rays. For some patients, x-rays can be helpful to get a better idea of the anatomy kind of inside their body. Treatment options, the easiest is behavioral. So some patients have been told by their cardiologist, their primary care doctor, they got to drink fluids all day. So they're hammering water all day and having a lot of leakage issues. And a lot of patients that I will see, they don't have to drink as much as they've been told they have to drink. I mean, they're kind of overdoing it. So we try to talk about, maybe spreading out the fluid throughout the day, not hitting it right at breakfast, lunch, and dinner, cutting back on fluids before you go to bed, so you're not getting up as much at night to pee. And then trying to time your voiding. If you know you tend to leak at around 3 hours because your bladder's full at 3 hours, then try to schedule a bathroom break at 2 or 2.5 hours. You can use smartwatches to kind of remind you. Nobody's going to know why the watch is going off. Maybe you can put it on soft vibrate so nobody hears it. But there are some things people can do. And we'll talk about also reducing irritants like caffeine and colas that are coffee, things like that. Physical therapy. This is pelvic floor physical therapy to kind of work on strengthening your skeletal muscle. Think of it as like you're working out, you're trying to make that skeletal muscle stronger so you have more functional resistance when the bladder fills, trap the urine. That's also Kegel exercises. And then biofeedback is when the physical therapist or someone puts these sort of leads on the skin around your perineum that helps them to figure out, are you using the muscles they want you to use when you're urinating? It gives them a little bit more objective data to try to help train the patients on how to use the right muscles to improve their urinary control. And then other options, pads, incontinence underwear. There's also incontinence underwear. I try not to use diaper because it has a kind of a poor connotation, but I try to always just say incontinence underwear when I see patients in the practice. And then a catheter. It can be an indwelling catheter that goes in the urethra, or it could be a condom catheter. It's a condom that sits on the outside of the penis that urine can drain into. And then penile clamps. We'll talk about this here in a second. So pelvic floor physical therapy, there is some good data. There's not a lot of data out, but the data that has been published, there is some convincing data that if you do pelvic floor physical therapy before your surgery, those patients will have better urinary control after their surgery. And what you're doing is you're working on, I tell patients, you don't even have to go see a physical therapist. You just pee into the toilet and stop your stream, and then start your stream, and then stop your stream and start your stream, just so you know that you're working on the urinary muscle sphincter and not the rectal sphincter. You don't want to be tightening up that rectal sphincter and not do anything to the urethra side. So once you know you're contracting the right muscle, then I tell patients just to, in the morning or sometime in the afternoon at night, you just want to do some slow contractions. You can be sitting in your couch, you can be sitting at the dinner table. You don't want to be standing. You just want to kind of be relaxed from your body, and then gradually tighten your muscles, the urinary muscle sphincter, hold it for 5 seconds, and then gradually relax. And it kind of mimics when you see people working out. You don't see people with dumbbells going as fast as they can. They're going slow to recruit all the muscle fibers, holding the dumbbell, and then slowly relaxing. So you can do maybe 20 a day. And I think it's a good idea to try to do that before surgery, especially if you think you may have some concerns about how the surgery is going to go, just to kind of bulk up that external sphincter. So when the prostate comes out, you have better reduced maybe early incontinence. And there's been data showing that if you do the pelvic physical therapy ahead of surgery, those patients tend to do better after surgery. Of course, if it happens after the surgery and you're just seeing the urologist, you can't go back in time and do that. But these are just things if you're going into the surgery, things to think about. And then lifestyle interventions, we talked about time voiding, reducing your fluid intake or spraying the fluid out throughout the day as opposed to hammering it all at the end of the day, reducing bladder irritants, coffee, Rockstar or different types of energy drinks that are loaded on caffeine, and then colas, dark teas, and then pelvic floor physical therapy. And then there's a study looking if you did pelvic floor physical therapy with bladder control strategies versus none, those patients had fewer incontinence episodes than patients that did none. So there's some good data, some preventative stuff that can be done before surgery. It can even be done after surgery. I would say that if you have significant leakage, trying to do Kegel exercises, any delta or change that you notice is probably not going to make a big difference. So I try to focus on the pelvic floor physical therapy after the surgery for guys that have milder or moderate degrees of incontinence, not the guys with significant leakage. This is a penile clamp. It's just the one here on the top left is the one that we sell in our office. It's just like a big foam paper clip that just goes over the penis. It acts as an external sphincter. It just compresses the penis, the erectile bodies, and the urethra. The vast majority of men cannot wear this device for more than maybe 30 minutes. I do have some patients in my practice that can wear it all day. You don't want to sleep with it on because it can cause some pressure, some damage to the tissue in the urethra. So I'll tell patients at night not to leave it on. You want to take it off at night to let the skin breathe. But there's, a small subset of men that can wear it throughout the day. And there's used to be, you just had to get it through a medical provider's office. But now you look on Amazon, there's a lot of different options out there. And you have a lot of patients that will bring in and show me the one that they ordered, and totally fine. If it's comfortable for you, that's great. If you can tolerate it for 30 minutes to an hour, some guys will use it when they go out for dinner because it helps them just to feel like, they don't want the smell of urine. They don't want to be leaking. It helps them to feel a little more confident. But after you get about to 30 minutes to an hour, it's pretty uncomfortable, and most men aren't going to want to wear it for longer than that. These are the surgical options. The sling is a hammock that sort of supports the urethra. You don't, and we'll kind of go through the stuff at the bottom of the slide about mild, moderate, and severe, but just so you know, the sling is just basically supporting the urethra. It's kind of resuspending it. When you cough or sneeze, that sling supports the urethra so the urethra doesn't prolapse down and cause you to leak. It's all internal inside the body. You don't have to operate anything. The sling does all the work for you. And then the AMS 800, also called, it's American Medical Systems, but it's an artificial urinary sphincter. This is a cuff that goes around the urethra. So that is inside the body, all internalized, and it's just squeezing the urethra, keeping it closed. So the vast majority of the day, the device is actually squeezing on the urethra and keeping it compressed. Then there's a pump about the size of my pinky finger that sits in the scrotum. And when you squeeze that pump, again, it's inside your body in the scrotum, the cuff opens up. And when it opens up, because there's saline in it, and it gets cycled to the balloon, but when the cuff opens up, the urine just exits the bladder and empties into the toilet. It's all based on fluid dynamics. There's no batteries or any electric power attached to it. And then gradually, with just pressure fluid dynamics, the cuff just fills back up and it closes back off over about 30 to 45 seconds, and now you're dry. There's the little pump that sits in the scrotum. When it's squeezed, it's fully depressed, so you know the cuff is open, but it'll gradually fill back up. And when it's full, that gives you the tactile feedback to know that the urethra is now closed and you can pull your pants up and go about your business. But when you look at this PPD as pad per day, for guys that are using 1 to 2 pads per day, 3 to 5 pads per day, those are mild to moderate. I don't like to use the pad per day because I get some guys that'll come in and say, I go through 15 pads a day, but you ask them how wet the pad is, they'll say, oh, it's just minimally wet. You get other guys that say, I'll go through one incontinence underwear a day. But when you tell them, they say, oh, I can wring it out. Well, that's a completely different volume of leakage. So while you can use pad per day, I like the Grant pad weight test because it just makes the curve straight for, or it makes the levels of playing field. So you know exactly what you're dealing with. So I saw a guy today, Had, I thought 3 to 4 or 5 pads per day leakage, but I said, look, let's do the pad weight test. He came in for a cystoscopy, so we looked inside his urethra. He did all the homework I asked him, so he'd done the voiding diary. So I knew his bladder held roughly about 600 milliliters, which is very good capacity bladder. But his pad weight test, it was 500 grams over 24 hours. So that's a guy with severe incontinence. He's going to benefit more from the artificial urinary sphincter. There's other guys though that are just as bothered as a guy that's severe leakage, but they've got maybe 150 grams of urine leakage a day. Not a lot, but it's still enough to affect their sort of confidence and their, kind of what they want, after the prostate cancer treatment. And those guys are going to be better managed by a sling. So just a heads up about kind of what those procedures are. The sling, it's an outpatient surgery. It's an incision behind the scrotum and that patch of skin between the scrotum and the anus. You make two little incisions up in the groin, and you kind of bring the sling up. You can see the arms here. They kind of go underneath the urethra and kind of resupport the urethra. And then these sling arms kind of come up to the surface of the inguinal crease. Then we kind of cut the sling there and kind of tuck it into below the skin. It's a procedure. It takes maybe 45 minutes to do. The update that they've done with this Advanced XP is it's got these sort of tentacles that hang off the side that kind of dig into the tissue. And what I've noticed is, and what the data has shown is that it helps the sling to last longer. So patients that, if they get a good result at 2 or 3 years, they're getting just as good of a result at 5 to 7 years. It's not starting to kind of stretch out and starting to sag and causing return of their urinary issues. Things about the Advanced XP sling that I wanted to make sure I remembered to say, you can't put another sling in. So say if the sling worked great and now it's starting to kind of loosen up with time, you can't just put another sling in. You can, but the surgeons I know that have done that have not gotten great results. So it's been something that's experimented with and it's not a great option. If you do have the sling put in, you can go to get an artificial sphincter though later. So if the sling does fail, we can always go for the more invasive artificial sphincter. The sphincter goes downstream from where the sling is, so they won't be near one another. It doesn't increase risk of infection or anything like that. So that's the sling. It's good for mild to moderate stress incontinence. It's a minimally invasive procedure. I talked earlier about the procedure. Patients typically go home from the recovery room. I leave a catheter in the bladder, have them take the catheter out after 2 days, and I see them about 2 weeks later, make sure they're emptying their bladder okay. I tell, no heavy lifting, squatting, bending, because we don't want to cause that sling to kind of loosen up. I tell, for the first month or so, just try to maximize your bowel, stool softeners, try not to do a lot of heavy lifting, straining, things like that. Things that have to be in place for the advanced sling to work is you do have to have a muscle sphincter that closes. If your muscle sphincter is not working, then the sling's not going to work because the sling isn't sort of acting as an external sphincter. It's just resuspending the urethra, but your muscle sphincter still has to be working. That being said, the sling also has to be able to suspend the urethra. So if you've had pelvic radiation, you've had prior urethral surgery, you've had multiple injections of like bulking agents in the urethra, that can cause this sort of like pipe stem urethra that's real fixed and rigid. But when you try to compress the urethra and lift it up, it just doesn't want to compress. So those patients don't get great results. I've let 3 patients convince me to do their sling with really mild degrees of radiation. And I'd say, the success, which kind of coincides with the literature, is maybe 40 to 50%, and it's very mixed. And I've only done 3 in like, I think 15 years since I've been in practice. I've had other patients referred to me that have had the sling put in after radiation, and they've had the sling erode through the urethra. I've seen some pretty bad complications, and those can be really difficult to manage. So I really, really carefully select the patients. Like I said, only 3 out of 15 years. And I really try to push people away from it. You also have to have a bladder that actually works. If your bladder's not squeezing, when you put that sling there, the bladder is just going to go into retention. So these are the things that have to be in place for the sling to be successful. The artificial urinary sphincter has been around. It's the original one that came out before the sling. This is more invasive. It's a cuff that goes around the urethra. There's a pump about the size of my pinky finger that sits in your scrotum, and then there's a balloon that cycles the fluid back and forth that's about the size of a ping pong ball. And that balloon, which we call the pressure regulating balloon, sits behind the rectus muscle on your abdomen. And then behind the scrotum in the perineum is where we put this cuff that goes around the urethra, and then the control pump just sits in the scrotum. You have to have manual dexterity. You have to be able to squeeze your fingers. You also have to have cognition. You can't have someone else squeezing the pump for you. So if the patient comes in and they don't have the cognition to be able to operate the device, we will not put it in. You got to have you got to be able to operate yourself. You can't have somebody else do it. The way it works, this just shows the cuff. So first of all, this is a penis here. This is the urethra. This is the bladder. Hopefully you can see my mouse. That's a control pump that sits down in the scrotum, and that's what you're going to squeeze. And then what happens when you squeeze, you got this balloon. This is a pressure regulating balloon that sits behind the bladder. But what happens is fluid exits the cuff, goes into the control pump, and then goes to the balloon. And then gradually over 30 to 40 seconds, the fluid cycles back out, back through the control pump, goes back into the cuff, and then closes back off. And you can see here, this is just showing when the cuff inflates, you have the urethra, which is the red tubular structure, is compressed. When it's deflated, the red tubular structure is open and you're able to empty your bladder. With the artificial urinary sphincter, you can have a bladder that doesn't work because what's happening is the cuff is actually what's doing the work, as opposed to the sphincter or the sling, which is just supporting the urethra. The sphincter actually closes off the urethra, and then when it opens, the bladder empties. So if the patient's totally incontinent and they're able to empty, it's just by gravity. When they squeeze the control pump, their bladder, the cuff will open, they'll be able to empty their bladder. So we don't want people self-catheterizing through the cuff, and you don't want to have a catheter inserted in the urethra because that pressure of the catheter on the urethra can cause some damage. You can have a patient who doesn't have a functional bladder though. I do think it's a good idea to have a bladder with adequate capacity. That way, they're able to hold the urine a little bit longer and they're not, if it's a small capacity bladder, those patients aren't going to be happy with this device because they're going to be peeing like every hour to 2 hours. So it's going to be fairly miserable. Overall, patients are super happy. These are some of my happiest patients in the practice. Mind you, you're taking patients. These are the moderate to severe leakers, so they're fairly wet. They're very frustrated. You've now put in a device in their body, and now they're dry. They're maybe using no pads or like a one security pad a day, and you can see it. 4 years, 6 years, very high success rate. And when these devices fail, they don't fail in the closed position. The tubing just breaks, and then the saline that's in the device just leaks out. And now all of a sudden, when they try to squeeze the pump, nothing's happening. So all of a sudden now they're incontinent. And these are the guys that want you to get the device put back in as quick as you can. They want to go back to where they were before. The devices on average last about 10 years and it can be replaced. I've got a couple of guys that are on their third or fourth artificial sphincter. So it can be replaced. Has a high success rate. These are the guys that were really miserable and now you're making their quality of life a lot better. In risk factors, so it can either get infected, where you have an infection of the device that can cause some problems where the device has to be removed. And then an erosion would be when the cuff actually eats or melts through the urethra. So now it's in continuity of the urinary system, and that's not going to heal. So if it's an erosion, typically that presents as blood in the urine, and we would have to take the device out. So the infection rate's very low, 0.5% to 7%. The device is coated with two different types of antibiotics that reduce the chance of infection. Patients that have a higher risk of infection, patients with prior radiation, advanced age, even smoking, poorly controlled diabetes, these are all things that just kind of impair wound healing, impair the vascularity of the tissue. So they put patients at a high risk of infection. And then in erosion, it's the same thing. If you've had radiation, I would even say even smoking, poorly controlled diabetics, previous urethral procedures where the vascularity of the urethra is not that great. Those are patients that we worry more about an erosion of the device. So in summary, there's two treatment options, or there's a lot of treatment options, but if you get to needing surgery, the sling can work great for guys with mild to moderate, and then the artificial sphincter can work for guys with more severe leakage. One last thing, you can get an MRI. You can go through airport screening security with the artificial sphincter in place. That's sometimes a question that comes up. And then the last thing is this fixincontinence.com site. This is with Boston Scientific, but they have some great literature. They've got little cartoons showing how the device works. And then they just released a new series. Think of it as like a Netflix series, but it's not an hour long. But little different vignettes looking at different perspectives, maybe like the partner's perspective or the patient's perspective and the post-radiated guy. And it essentially just goes through and just shows kind of how this surgery, whether it's the sling or the sphincter, has helped the patient out. Now, these are real patients, but they're patients that have worked with Boston Scientific, and these patients have had a good outcome and they just want to share their experience. And the name of this series is called Dry. It was just released within the last, I think, 6 months, and I would highly recommend looking at that if it's something you're interested in. So we're going to kind of pivot now and talk about erectile dysfunction or sexual health. And we'll kind of talk about, pills, injections, vacuum pumps, and then kind of the big thing we'll talk about at the end is the surgical way we can manage patients with erectile dysfunction. Um, if you have a robotic prostatectomy, we're taking the prostate out, but the nerves that help with erections run alongside the prostate. So if your disease is controlled and we can sort of tease those nerves off and spare the nerves and we can take the prostate out, there's a good chance that hopefully those nerves, maybe they might be stunned, but they can hopefully recover. Sometimes patients have really advanced disease, maybe on the right side of their prostate or left side of their prostate. So the surgeon may decide to not spare the nerves on the side where they know the cancer is more aggressive to make sure that they don't leave any cancer behind. So these are just, people ask, well, how did I get erectile dysfunction after prostate cancer? It's these sort of cavernosal nerves, or the nerve bundle that runs alongside the prostate, not the cavernosal nerves, sorry. For patients with prostate cancer that have surgery, roughly a quarter to three-quarters of men who have a sort of a quote nerve sparing procedure can have some degree of erectile dysfunction afterwards. It could be mild, moderate, severe. And for the most part, I tell guys, you don't have to wait a year. If you're getting no erections at 3 months, maybe you had a really advanced cancer, they know they didn't spare the nerves. You don't need to wait a year to get something done if you've already burned through the non-surgical treatments. But if you're seeing some steady improvement, I think waiting a year is a good idea because you may have some continued improvement. As far as radiation, again, we talked earlier, it's hard to compare the different radiation treatments. There's different types of radiation, and even the energy ablative treatments we talked about, like HIFU and cryo. And then there's brachytherapy, which are the seeds, and then the external beam radiation. And you can't really get a firm number, but I'd say I just tell my patients because it's hard to quote the data because it also depends on the patient's individual risk factors, if they're obese, if they're a smoker, if they're diabetic, what type of, if they how much radiation they received. Was it, was it a higher grade cancer or a lower grade cancer? Did they get combined radiation? But roughly, I'd say, look, at least half of men are going to have some degree of erectile dysfunction. And of course, if it happens to them, I don't have to worry about the percent incidence. I just know they've got erectile dysfunction. So now we're going to go ahead and treat it. So the easiest thing to try is the pills. This would be like your Viagra or sildenafil or Cialis, tadalafil, and then there's other variations too, but Viagra and Cialis are the most common. And then there's the vacuum erection devices. These is a pump that goes over the penis and by negative pressure kind of pulls blood into the penis. And then there's cavernosal injections. We'll go over all these, and then the surgery. As far as the pills, these are the phosphodiesterase inhibitors. Viagra and Cialis, I routinely just prescribe Cialis. Viagra is great. I do notice with Viagra, there's a little bit more headache, facial flushing, sometimes some blue-green color issues with Viagra. The upset stomach, I've not noticed a lot of that. But I've noticed that people are going to have side effects. It's more common, I think, with Viagra or sildenafil. The other thing I don't like about Viagra is once you take it, you're kind of on the clock. The medication takes about 6 hours, so it's hard to be spontaneous. You kind of feel like you got to sort of seal the deal within 6 hours once you take it. Whereas with Cialis, it's 24 to 36 hours, so you can be a little more spontaneous. You don't feel like you feel like you can go out to get dinner and the medication's working in the background, and it's ready. If it's going to work, it's there ready to work. You do have to be stimulated by either visual or touch for the medication to work. It's not just going to work without you having some sort of stimulation. Of course, if you're a cardiac patient, you're on nitroglycerin, we're definitely going to want you to talk to your cardiologist before you start these medications because they can cross-react with nitrates. The vacuum erection device can be used in conjunction with the pills. It's a little more clunky, but we do have some patients that do like it. But it's essentially a tube that fits over the penis, and it's either by manual or battery powered. It'll sort of pull blood into the penis by negative pressure. And then there's a band over the base of the tube that then rolls down over the penis. You can see it here on this photo. And then it basically just acts as a constriction ring to maintain the erection. Some of the problems with this is that because it's compressing the urethra and the erectile bodies, it can sometimes make ejaculation uncomfortable because the ejaculation gets constricted by the ring. It can cause some numbness, some discomfort, maybe some bruising. And for some guys, that's a big reason they go ahead and stop. The nice thing is you don't have to pay a lot of money with Amazon, comfort from your own home. You don't have to go to like, you can just buy a cheap, sex toy type version that's maybe 20 or $30 if it's something you want to try. I tell my patients, don't invest in the high grade medical device ones that are $400 or $500 if you just want to try and see if it's for you before putting down a bunch of money. I will say where I do use this procedure or this vacuum device is for patients who want to maximize as much length on the penis before we put an implant in. I'll have them use a vacuum erection device to kind of help augment penile length before we do the penile implant, just to try to get the penis stretched out in anticipation of us putting the cylinders in. Penile injection or intracavernosal injection. This is trimix, quad mix, bimix, caverject. You may have heard all these words, but essentially this is different. This was present before we had the pills, but it's an injection. You think of the erectile bodies, there's sort of the right and left corpora, the urethra's on the bottom, but you're injecting at 2 or 10 o'clock right into the erectile bodies. And it sort of creates an erection. It bypasses the need for the nerves to work. It works a little bit better in diabetics than the pills. Diabetics also, if they're used to injecting insulin, do a little better with this because they're used to injecting. Downsides of this is that if it's predominantly for the ones that are available nowadays. It has to be kept in a freezer, so it's hard to travel with it. So we go on vacation, it's gonna be hard to bring it with you. You don't have to be stimulated. I mean, not to be funny, but you can sit and watch paint dry and inject your penis with one of these pharmacologic mixtures, and it's going to create an erection immediately. So you don't have to be stimulated. But for some guys, it's a mood killer. They're putting a needle under their penis. So, there can be some initial excitement about it because they're getting great erections, and then there can be a fall off as patients kind of become less enamored with it. And then lastly, the penile implant. This is just like the artificial sphincter in the sling we talked about for incontinence, is entirely inside your body. No one's going to see it. If it's your partner, they're going to know you have it because they're going to be able to feel it, but it's not like poking out and creating sort of a weird appearance. But essentially, the nice thing about the implant is that you control how long the erection lasts. If you have good sensation, if you're able to ejaculate, if you've had a robotic prostate, you're going to have a dry ejaculate. But if you can orgasm, you're still going to be able to do that after the penile implant. I do tell patients when they come in, there's definitely an understanding of what the implant can do and what it can't do. What it cannot do is take you back to when you were a 20 or 30-year-old and had this, nice, healthy vascular erection. Because when the penis, or even before the surgery, if you've lost length because of the prostatectomy, if you're not getting erections as often, that's why I recommend the vacuum device to try to maybe get some length before we do the surgery. You can even use or you can even use injections with a vacuum device just to try to maximize length before we put the implant in. But the implant can only give you the length that we can get when we stretch your penis. I do have some guys come in and they say, well, when I did injections, when it was working, I had much longer penis than after the implant. Well, when you do the injections, you're getting blood into the penis. You're getting stretch on the erectile bodies. You're also getting some blood into the head of the penis. And it's just going to be a different feeling erection than the penile implant. That being said, if someone cannot get an erection at all, and the penile implant gives them rigidity to where they can be sexually active for penetrative intercourse, and it allows them to satisfy their partner and they can control a longer duration of an erection, that's great. But to go in there expecting something that the implant can't deliver is, I think, something that I always try to basically make sure the patients understand. That being said, once a device goes in, it's a high satisfaction rate. Patients are really happy with it. I do tell them it's a tissue expander. So what you need to do is I'm going to want them to inflate, deflate the device every day for the first 6 months. Even if before they get in the shower, just inflate it before you're in the shower, deflate it when you get out if you're not going to be sexually active. And that device over the first 3 to 6 months is going to stretch the tissue out. You are going to get hopefully regain some length. We can't promise people what that length's going to be. It's also going to get you comfortable using the device. It's also going to make it to where the device just feels like second nature. What you're going to find is you're eventually getting more pumps into the device. And that just tells us that the tissues are starting to stretch out more. So you have to have some skin in the game when you get the implant. You just can't get it put in and say, I'm just going to use it when I want to be sexually active. I do feel like patients need to be engaged in kind of the first 6 months or so and cycling it every day. It's coated with an antibiotic substance, just like the artificial sphincter. It's called inhibizone. It's two different antibiotics that are attached. When the device is deflated, it's the penis looks natural. When it's inflated, it's gonna be rigid enough for penetrative intercourse, and it's been around for 50 years, so it's got a long track record. And it's a good device. This just shows what the device looks like. There's two cylinders that sit in the erectile bodies on the right and left. Then there's a control pump. This is going to be different than the artificial sphincter. The artificial sphincter kind of looks like my pinky finger. The control pump for the penile implant is kind of a circular structure, and that's what you're going to squeeze with your fingers to get it inflated. And then the reservoir is larger, which is the fluid that's going to cycle the fluid back and forth. It's much larger than the artificial sphincter. The artificial sphincter, we put in about 25 cc's of saline or milliliters. For the penile implant, it's anywhere between 65 to 100. So a lot more fluid. We try to tuck it behind the rectus muscle. For some guys that are thinner, we sometimes have to work a little bit harder to make it concealed. And some patients, they may feel the pressure getting ballooned, but overall, it's for the most part, it's concealed for the patient. The inflatable device, previously there was this MS, momentary squeeze pump, where you had to squeeze the control pump fully to get the device to sort of pull fluid in and inflate. This new Tenaccio pump has come out over the past year. And the thing I like about it is, number one, you can see it has more of a rectangular appearance to it, or a square appearance to it. So patients can actually grab it a little bit better, whereas this one's more of a circular, so their fingers would kind of slide off sometimes. The other thing that's nice about this is you can, what I call flutter pump. You don't have to squeeze it you don't have to depress the pump as much, or the pump as much to get the fluid to inflate. So I do have a device in my practice. I have patients kind of squeeze so I can see what their grip strength is. And for some patients, their partner can help inflate the device if they don't have good grip strength. But with the Tenaccio pump, I think it's a little bit easier for patients to master that. And then there's the LGX, which expands in length and girth. And then there's a CX, which expands more in length. And then the CXR, which is for patients that have maybe, a more narrow caliber erectile body, maybe from radiation or prior medical issue called priapism, where they get a prolonged erection and get scarring in the corporal bodies. If you look online enough, you're going to say, oh, patients come in and say, oh, I want the LGX. That's a gold standard. Well, it's not, because the LGX is great up until you get a certain length erectile body. Once you get beyond a certain length, the CX is going to be better because it has more push, is going to give you more rigidity. So I tell patients, we're going to put the one in that's the best for you, but they're both excellent. And I've had patients, even with the CXR put in, that still get great erections and they're still able to be sexually active. Oh, and then just to go back, there's a malleable implant called the Tactra. It's a little more rigid. Think of kind of like a Gumby. It's like a Gumby penis, where you can bend the device where you want it to be. And some patients just aren't good candidates for the inflatable, and the sort of malleable implant can sort of service those patients. I do maybe one every couple, maybe 3 or 4 years. So not a big part of our practice, but it is out there for patients that need it. So overall, it's also an outpatient procedure. You can make the incision either below the penis on the scrotum or above the penis. It's called either penis scrotal or infrapubic. The implant goes into the erectile bodies. There's a control pump that sits in the scrotum, and then I'd make a separate counter incision up on the belly because I feel like I get a better placement of the balloon. I'll leave a wrap around the penis to kind of keep things compressed. I'll leave a catheter in the urethra, and I leave a drain in the scrotum. And then the next day, about 90%, 80 to 90% of our patients go home the day of surgery. We see them the next day in the office, take the drain out, take the catheter out, take the dressing off. And then we leave the implant about 20% inflated for the first 2 weeks, just to keep those cylinders kind of seated in the erectile bodies. And then after 2 weeks, we bring you back, deflate the device. From my experience, I've noticed about half the guys are able to start inflating, deflating the device that day. The other half need maybe another 2 weeks before they're ready to start what we call cycling, or inflating, deflating the device. And then there's going to be about 4 weeks of homework. And then after those 4 weeks, you can start using the device. I typically give patients, and then for the first 6 months, I'm going to want them to inflate and deflate it every day, because it is a tissue expander, and it's just going to make the patients happier in the long run than if they just use it when they want to use it. I give about 10 tablets of oxycodone. I will occasionally get patients that need a refill, but for the vast majority of patients, they don't need a refill. And then Tylenol to kind of supplement the oxycodone, a couple of days of antibiotics, and then a stool softener. Um, Infection rate also very low, 1 to 3%. It can be higher, up to 5 to 10% in patients, they have poor tissue healing. Again, it's the smokers, patients that are immunocompromised where they've got some, maybe they're on medications that compromise their immune system, and then poorly controlled diabetics. And then the erosion rate would be, this is when the device actually perforates through the tip of the penis, and typically that's for patients that aren't fully deflating the device when they're not using it. You just want to kind of let that tissue breathe. So I do recommend patients fully deflate the device when they're not using it. And then patients that have poor tissue healing, poorly controlled diabetics, smokers, and post-radiation patients. Getting close to being done here. edcure.org is the website for Boston Scientific that deals with erectile dysfunction. They have a similar series for patients, similar to the dry series for patients with incontinence, called HARD, kind of a play on words, hard penis, erect penis. Also, when it first came out, I mean, people don't really know how to talk about this, so it's also kind of a difficult or hard topic to talk about. So they go through the perspective of the partner and the patient, and give different clinical vignettes of patients that have had the implant put in. And I think a lot of my patients that have watched that have also found that to be sort of very helpful. And that's pretty much it. This is my address. This is our phone number for work. This is my name. I practice at our Trent office. I don't practice at the Valley office. However, I do have a PA that I work with whose name is Justin Overhoff, and he and I work as a team, and he's excellent. I'm really happy to have him work with me. And he has a clinic out at our mission office. So I do have some patients that see him, and then end up seeing me on the day of surgery. And there's also other providers in our office that will refer patients to me, and we get patients from outside of our hospital or our practice. Even though we're called Spokane Urology, I try to tell patients we're the only practice left in Spokane, and we're really more like inland Northwest urology. We cover a pretty broad geographic area, upper Northeast Oregon, Montana, parts of Idaho. I've even had patients come out from Alaska. That's very uncommon, but we do cover a pretty wide geographic area, and we do our best to service our patients, but we are unfortunately kind of an underserved area with a limited number of urologists. But I'm very happy to help patients with this. I'm more than happy to answer questions. I'll kind of turn it over to Mike to see if there's any questions from patients.
Yes, so as a reminder, please use the chat feature to submit your questions. But we did have a number of pre-submitted questions come in. So I'm going to start with the first one that I received. This gentleman said, I had prostatectomy done 2 years ago and then had to have radiation as well. He said erections were bad after the prostatectomy, but incontinence at first was fine after radiation, but seems to be getting worse.
Yeah.
Why is this getting worse? Is the question.
Yeah, great question. So, after the surgery, and I was going to put some data in about that, but I didn't put it in because I didn't want to get too much in the weeds. But after the surgery, if you've had some damage to the external sphincter, to where the external sphincter is not working as much, and then on top of that, you get radiation. It can be two things. It can be combined or it can be separate. There could be some additional damage to the external sphincter muscle where it's just not working as well. It could also be from the radiation that there's some bladder fibrosis where now the bladder fills with urine. It doesn't stretch as much and it doesn't sort of fill in a relaxed manner. But when it fills, it's really high pressure. So it's putting that force somewhere, and it's not going to go up the ureters into the kidney, but it's going to put more of that force against the external sphincter. And that's why sometimes the leakage can worsen. So when I see these patients, that's why I do a cystoscopy. I try to figure out what their bladder capacity is, figure out how compliant or stretchy their bladder is. If their bladder capacity is great, then I chalk it up and say, look, it's probably your external sphincter. It's just not working as well. But if the bladder is not working as great, depending on their bladder capacity, we can put an artificial sphincter in. I try to use like 250 to 300 milliliters as what I feel like should be an acceptable bladder capacity. And in some patients, we'll inject Botox into the bladder that kind of helps to stretch the bladder out to kind of game the system in our favor to give more capacity. And that can be repeated like every 6 months or so. And then other patients, we can put them on, anti-spasm medications like oxybutynin. They can also help.
Thank you. Now, that's another
Yeah.
question related to incontinence. This person asked, it seems that there's certain days that are worse than others. Were there things that I can do to level that out, or is that normal for certain days to leak more than
I,
others?
Yeah, that's a great question. I think it's sometimes looking at your diet. Like if you're drinking more fluids during the day, if there's certain days where you're just physically more active and that muscle just gets more tired during the day and you tend to leak more towards the end of the day, that can sometimes impact it. But a lot of times it's just behavioral. Maybe on the weekends you do better than when you're on the weekdays because you have closer access to a toilet, so it's easier for you to get to the bathroom. Um, some patients can do a subtraction diet and see if there's sort of irritating foods or fluids that kind of stimulate these. But beyond that, other things is diuretics. Some patients are on water pills, and they notice that that can sometimes, if they're not taking the water pills every day and they're using just intermittently, on the days they take the water pills, they're just making more urine. But it can be multifactorial, and a lot of times it requires kind of sitting down to the patient and just figuring out what they're doing on these days when they're worse than days when they're not as worse. Good question, though.
I apologize for this. This patient provided a lot of context
Oh,
information, but
yeah.
just to make it more broadly applicable, basically stems down to if somebody has both ED and incontinence, do they have to choose which they treat, or can both be addressed?
They can both be addressed. And, this is where, I mean, every urologist has their take on how they choose to manage this. I can just tell you after 15 years, the way I've managed it, I've put an artificial sphincter, depending on their degree of leakage, you can do the advanced sling or the artificial sphincter on the same day as a penile implant. I have not done that. I've stopped doing that. Just because those two surgeries on the same day, I find it's just overwhelming for the patient. It can make it really difficult in the recovery. So what I typically start off first is with the incontinence procedure because if you can make the incontinence better, maybe now, if you fix the erections first, but they're leaking, then they're kind of leaking when they're having sex. So I feel like almost every patient's like, yeah, I want to fix the incontinence first. So we typically fix the incontinence first. And then maybe we can try injections or other things to try to work on augmenting the penile length or trying to get them some erectile function once they're dry. But then if they're still bothered, we can always put the penile implant later. But I have personally just chosen to stagger this. If other surgeons say they put them all in on the same day, that's totally fine. I just have my preference on what I think works best for my patients, just seeing kind of how they do on the recovery process. But they both can be done. Some patients, it can be a little bit harder depending on their their history. There's things we have to do sometimes on the artificial sphincter to get them the best possible outcome that might require using some of the erectile body tissue to give us more of a cushion for that cuff. And in those situations, sometimes it is harder to put the penile implant later. It can be done, but these are things they're kind of now we're getting into the weeds where I would kind of have to sort of counsel that patient individually. But long and short is answer is you can treat both of those for most patients.
And those gentlemen said that he lost his sex drive and ability to get an erection after prostate cancer treatment. But he's worried that if he's got low testosterone, is that something he can treat? And if so, is that something that could address his erectile dysfunction as well?
Yeah, so if you take like that's a great question too. So again, I'd have to know his backstory. Like if he's on androgen deprivation therapy and they have to chemically castrate him to where he's got no testosterone, there is some data saying that if you give testosterone replacement, that's now kind of found its way into prostate cancer treatment. I don't manage our advanced prostate cancer patients, but I do know I have some patients on testosterone in conjunction with other treatments for their prostate cancer. But if you've had prostate cancer treatment done and they need to keep you chemically castrated so your cancer is not going to progress, well, we can't give testosterone, and that's just unfortunate. However, if you've had prostate cancer surgery and your testosterone is low, you can actually get testosterone replacement. I mean, there's men that have had their prostate taken out, they're walking around with normal testosterone levels, and if your testosterone level is low, we can replace your testosterone. What we don't want to do is overshoot it and then give your cancer kind of that food source for the PSA to progress. So I have some guys that are definitely on testosterone replacement therapy or years out from their prostate cancer surgery. Their PSA is stable. There's no recurrence. So you can replace the testosterone. What testosterone is going to do though is it's going to give you more energy levels. It's going to help with bone strength. It's going to help with cognition. It's going to give you that sexual drive. And if the sexual drive is what you need to get to be interested in wanting to have sex, then it'll help you to have erections. But it's not going to magically make the erections better if those nerves are damaged.
You. Now, somewhat. related to nerve damage with erectile dysfunction. If somebody gets an implant, this person asked, are they able to still orgasm?
Yeah, so you'll still be able to orgasm. If you've had your prostate taken out, it'll be a dry ejaculate. But if you're able to orgasm before the surgery, or if you're able to orgasm before the implant, you will be able to dry orgasm after. If you've had radiation treatment, most men aren't going to ejaculate with sort of any sort of seminal fluid either. But if they were able to, for some reason, ejaculate before the radiation therapy or after the radiation therapy, they'll still be able to ejaculate after the implant. So orgasm is still there. But if you're not able to, if you're able to get an erection with like maybe a vacuum pump or injection therapy, but you just don't ever, for whatever reason, get an orgasm, the implant's not going to fix that. It's only going to be if you had it before the surgery, it will preserve it afterwards.
This gentleman says, I had a prostate ablation 9 months ago.
Maybe
Um,
it's a Bayesian, maybe an ablation. Maybe it may have been like yeah, maybe an ablative treatment for BPH. I'll let you finish the question. Sorry, Mike.
and so they still have low-grade prostate cancer. Is it normal for them to feel pain in their prostate sometimes after that?
Yeah, it would. So they may have had some sort of ablative treatment for their prostate, like HIFU or cryotherapy. That would be a question where you can have some, nerve irritation or, again, I'd have to talk to the patient, know more about their background. But if you have some sort of pain from the procedure that was done, which can happen, um, yeah, it can happen. Yeah, I mean, it can happen after radiation therapy. I've had men that come in and say their prostate cancer is treated. Typically, this happens like 5, 10 years after the radiation because it's kind of always kind of working in the background. And you find at 5 to 10 years, that's when some of these major complications happen from the radiation. But some guys can just have chronic pain, related to the radiation, and there's nerve medications. I typically will start off with one called Lyrica. It's called pregabalin to help with nerve pain. And I try to sort of titrate that dose to see if we can find something that works for them. But the pain could be due to many things. We'd have to evaluate the patient and make sure the urethra is open, there's no scar tissue. Is there any potential chance of like a fistula that might be trying to develop? I mean, these are all things that would have to be worked up.
And that's a water ablation. It's done.
A water ablation. Yeah, I don't know what the procedure. I mean, HIFU and cryo are the most common, but there are water ablative treatments for BPH that maybe they found prostate cancer when they did the ablation treatment. But I'd have to know more information about that. So,
It looks like we've got no further questions this time. So I put a last call in for questions. And as we do that, Dr. Voelzke, I know you've got your info on the screen there, but if somebody does want to get a hold of you, what's the best, most effective way to do that?
yeah, again, just kind of, I don't want to use it as an excuse, but we're 9 urologists and we need probably 20, 22 in the area. So, what we've tried to do, we've done these video conferences in the past and we have kept track of the patients that have called in. You can say, I heard the video conference from Dr. Voelzke. I'd like to see him in the office. If you're an existing patient in our practice and you've seen by another provider, I don't think we've had problems with these patients kind of switching over and saying, hey, I'd like to see if Dr. Voelzke could, do my potential surgery. And of course, if we see it and we can, then great. If I see and we're not a great candidate, then we'll figure out maybe you continue to follow with that surgeon or you follow up with me. But if you just give the staff your name when you call in, they'll keep tabs of this and they'll make sure the patient gets in to see either me, hopefully me, but if I can't get them in a timely manner, then it would be Justin to kind of get things started. That's the PA that I work with.
Thank you. It looks like no further questions this time. So I want to leave the floor to you for any last words of wisdom, Dr. Voelzke. But before I do that, I want to really thank you for all the time you spent on this, all the additional research that you did here to present the most relevant information, and thank everyone who's on here. It's not easy to take time out of your day and to take a step forward in some of these scary issues, men's health related. So thank you all for attending.
Yeah, I would just echo what Mike said. I really appreciate the relationship we have with Boston Scientific, and I think it's just trying to get this information out there. Each patient's individualistic on how the leakage or erectile dysfunction bothers them, and I try to basically treat each patient kind of as their own N of one. But we're always happy to help. Try to be patient with us as we try to get people into our practice. But I'm also only human, not a miracle worker, and I try to do as best as I can for every patient that we see.
Dr. Voelzke, again, thank you so much for all the information and for your time. As a patient said, wow, excellent presentation, and thank you. It's a direct comment
Yeah,
from someone who attended, and
great.
I couldn't agree more. So appreciate this. This concludes tonight's Men's Health webinar. Have a wonderful evening, folks. Enjoy the rest of March Madness,
All right.
and enjoy the warmer weather. Good night.
Thanks.